Hello, everybody, and welcome to June's edition of St. John's Cancer Institute's Be Inspired Speakers Series, the Survivorship Umbrella. My name is Jean Goldsmith, and I'm a Development Director at St. John's Health Center Foundation. As of January 2021, the Cancer Institute's name changed from the John Wayne Cancer Institute to St. John's Cancer Institute. The licensing agreement allowing St. John's to use the name and likeliness of John Wayne on the Institute and the fellowship program expired. The change is in name only. It will not impact the Institute's operations in any way, and the fellowship program will carry the name of the physician who founded the Institute and be called the Donald L. Morton, MD, Complex General Surgical Oncology Fellowship Program. St. John's Cancer Institute will continue to provide excellence in research, education, and cancer care through innovative clinical trials and laboratory research, the education of the next generation of surgical oncologists and scientists, and of course, state-of-the-art treatment for our patients. Going forward, we will expand and deepen the focus of our main pillars of cancer research, immunotherapy, genomics, and precision medicine. Before we get started today, I'd like to give you a little information on how to ask the speakers questions, which we really hope that you will do. As you will notice, everyone but the presenters are muted so that we will be able to hear them well. In order to ask questions, you will need to use the chat function on your screen. The chat function looks like a thought bubble and is located at the bottom of your screen. We will see your question, and Dr. Martin will ask the physician that question. If we do not get to your question during the webinar, I will send you myself or someone else will be sending you a response to your question. And if you have a question after the webinar is over, please send us an email and we will respond to that. You can just reply to the emails that we have sent you. That will be the best way to get to us. We have a very interesting hour in front of us as we will hear from a medical oncologist, a psycho-oncologist, and a nurse practitioner who all work in cancer care and survivorship. We will learn about services available to a patient and to their loved ones that will help everybody manage through the cancer journey. I'm very honored to introduce the panel today. One of our presenters is Dr. Shanthi Gowrinathan. She's the Director of Psycho-oncology and Cancer Support Services at Providence St. John's Health Center. Dr. Gowrinathan is one of a few psychiatrists primarily focused on oncology in Los Angeles in a field known as psycho-oncology. She brings her expertise to St. John's Cancer Institute, growing our supportive care programs and leading a team that focuses on the mental health aspects of a patient's cancer journey. Dr. Gowrinathan, can you tell us how you became interested in psycho-oncology?
Hi, thank you, Jean. So psycho-oncology for me encompasses all the really fun parts of being a physician. So there is the sort of medical manipulation of understanding why patients are having the symptoms they're having, understanding what part of the body, all of that. But then there's also the really lovely part of getting to sit with a human being, somewhere along their cancer journey and helping them to have better quality of life or to have a better moment or to find a way to sort of rise above whatever they're going through. So it really is a melding of both like the art and the science of medicine. And so it's incredibly rewarding.
That's great. Thank you.
Thank you for having me.
Yeah, thank you for joining us today. Another of our panelists is Anna Rocha. Anna is a nurse practitioner specializing in cancer survivorship. She's worked in all areas of cancer care, inpatient, outpatient, and in the infusion centers. And her focus is on empowering patients and families during treatment through education, support, and advocacy. Anna is the constant presence for cancer patients in our cancer center, making sure there's a clear communication between oncology and survivorship teams. Anna, what is the most rewarding aspect of your work?
Well, Jean, that's a great question. There's so many different aspects that are rewarding, but really it's that connection that I am able to form as a nurse practitioner with 16 years of experience in oncology in all different areas, from infusion to working in the clinic to working in the hospital. And really it's establishing that relationship, that connection with that person. Cancer is really all that I've done in oncology. It's where I started and where my passion lies. So thank you.
Well, thank you. And thank you for everything that you do for our patients. You really are an angel to so many people, honestly. Our third presenter is Dr. Marliou Terpenning. And Dr. Terpenning has been the Director of Medical Oncology at Providence St. John's Health Center, as well as the Managing Partner of Santa Monica Hematology and Oncology Medical Group. She is a medical oncologist with special interest in breast and gynecologic cancers, new models of cancer care, and bioinformatics. Dr. Terpenning has been a strong advocate for survivorship services and was the founding director of the Cancer Support Program here at St. John's. She's now mostly retired, but she remains very active in clinical research. Dr. Terpenning, you must be happy to see how far survivorship has progressed. What excites you about the future of survivorship programming?
I'm thrilled to see how this program has grown from a dream to a real full integrated service that meets the needs of those with cancer from diagnosis through treatment and beyond their life after treatment, and provides support for so many aspects of patient care. So I'm absolutely thrilled to see what the program is. And it still has room to grow, as all programs do. I think one of the biggest contributions that the program has made so far is actually raising the awareness of all of those in the medical community of the importance of survivorship, not just treatment for cancer, but helping people get through their treatment and to thrive after their treatment. I think that this could be improved further by integrating with the general medical community and helping people in different specialties see where their needs, the survivors' needs could be met by having specialized care, for example, in cardiology or endocrinology. I think there's opportunities for education of the whole healthcare system at St. John's, which is already a tightly integrated healthcare system, which permits relatively easily fast interaction between physicians and other healthcare providers to optimize patients' experience and recovery from cancer. I think prevention is another opportunity. Hereditary cancer program with excellent genetic counselors is part of the survivorship program. And cancer prevention, secondary cancers from hereditary cancer and also from having had non-hereditary cancers is becoming an increasing issue since we have so many survivors today, almost 18 million. And so I think that that's an area of growth, again, through integration with primary care physicians and specialists. And lastly, a pet love of mine is increasing physical activity because it builds resilience emotionally and physically in those who've been impacted severely by cancer diagnosis and treatment. So the outdoor activities that can be facilitated through community collaborations, the strong physical therapy and rehab through our performance therapy contributions to the cancer program, all of these are real opportunities and uniqueness to the program that I think makes it so very special.
Thank you, Dr. Terpenning. And moderating today is Dr. Neil Martin, the Interim Executive Director at St. John's Cancer Institute. Dr. Martin is a neurosurgeon and is also the Regional Medical Director of Neuroscience for Providence, Southern California, overseeing neurosciences for the Providence hospitals and clinics across all of Southern California. So take it away, Dr. Martin.
Thank you, Jean. It's really a privilege to be here with three of our extraordinarily valuable team members for cancer care. Let me just start with Anna. Anna, can you help us define the service here? Who is a cancer survivor? What's the definition?
A great question, and a question that some people don't necessarily relate to the term. But in the early 1970s and 80s, there was little known about cancer, and there was very little therapy available. People with cancer were often called victims. In 1986, a small group of 23 people gathered together, some with cancer, others who had completed treatment, nurses, social workers, psychologists, and oncologists, and officially coined the term and defined cancer survivor as any person from the moment of cancer diagnosis and for the balance of their life. And 23 years later, they went on to form the National Coalition for Cancer Survivorship. So any person who has been diagnosed, whether they have received treatment, whether they haven't started treatment, whether they're early stage or late stage, is a cancer survivor. And that term has also come to define people with, not just people with cancer, but also their family members and their loved ones.
So really, it's anybody who has a diagnosis of cancer and anyone who had a diagnosis of cancer anytime during their life.
That's correct.
Well, it's great. It's great to have so many people who are adding to the traditional medical strategy of dealing with physiology and biology to really help the person, to help the emotional being that is afflicted with cancer. So, Dr. Gowrinathan, what exactly are cancer support services?
So cancer support services are sort of a multidisciplinary approach to helping support patients with ancillary services that will help them, both recover from treatment and also, sometimes acutely we can help people during treatment to tolerate treatment better and get through things with a little bit more strength. And then really at any point in the patient's either treatment or recovery or their journey as a cancer survivor afterwards, the idea is to look and see where we can optimize patients' well-being. And so the different factors include psychiatry, psychology, and social work. We have Anna Rocha, who does survivorship preventative care. So we really focus on making sure that we catch things early, that we are doing what we need to do to prevent sequelae of cancer treatment. And we have a section in there for bone health as well. We have chaplaincy and palliative care and pain management. And we all work together on a sort of a multidisciplinary team that meets, collaborates, talks about patients. We make sure that if one of us finds that the patient has a need that hasn't been met, that we get that patient to that service. And then we collaborate with those providers. And I think one of the really essential things that we do is go back and talk to the oncology teams and really act as a liaison and allow patients better communication with their oncologist.
Right. Dr. Terpenning, you have great experience as an innovator in this area and as a practitioner in this area. How do patients learn about cancer support programs? Who's going to tell them?
Good question, Dr. Martin. Oftentimes it is the oncologist or the surgeon themselves, nursing staff, friends, flyers in the offices. Basically, when you're newly diagnosed with cancer, your whole world is turned upside down for that and your family. So you don't think very clearly and couldn't go do a Google search at that point in time, but your family might and look for help for you. We have a very good website for the St. John's Cancer Program, and there's a link on that from the Cancer Support Center to be able to review all the resources that are available. And again, that's for family to help out. With an individual, it's just usually trying to get from appointment to appointment with the head spinning. I think that people need to be forthright and ask their doctors or nurses if there's any help for them, if they have particular problems, if they're having issues with their family, young children, with themselves, with work, with social needs such as childcare, et cetera. And I think that kind of dialogue opens up referrals very readily. But usually it's in the first few days after cancer diagnosis, when individuals met with their doctor, surgeon, or medical oncologist, that the story begins to unfold and the shock starts to wear off and they begin to be aware that they need help. And that's when they ask for help. And I think that one of the great contributions of this program has to become a visible source of help and to make the community aware, primary care doctors, oncologists, surgeons, aware that there is a resource to help individuals. Oftentimes physicians and their staff can be very hectic, and it can be hard for them to stop and pause. So to have this integrated resource, absolutely amazing for patients and their families to be able to have people to help them as they begin to make the first steps in this journey towards treatment and wellness.
Terrific. Anna, we're fortunate to have you all working with the St. John's Cancer Center, but there must be other resources outside of our organization in the community that patients need to be aware of. How do you help them navigate through the different levels of service and the different organizations that can help them?
Right, so another great question. It really depends on the individual. You know, some people need a little bit more help than others at different times, and other people need more. So it's really just aligning the resources that they need. There are plenty of community resources, national resources, and we have certainly a variety of different services available to people that get treatment here at St. John's. So it's really just identifying what their needs might be early on and surrounding them with the support that they need.
Thank you. Dr. Gowrinathan, when you encounter a new patient for the first time, how do you begin to go about understanding what their most pressing issues are?
Well, I think that, you know, very rarely I'll get a patient early on in their cancer journey, but it's more likely that they've been a cancer patient for a while. And I think people are very good about advocating for themselves nowadays. People have educated themselves on their cancer. They're good about noticing and talking about things. So I think it's really just about listening and figuring out where that person has some holes in terms of what they're able to cope with and what is really sort of overwhelming them. And then it's funny how there's these trickle down effects. So when you treat one thing for someone, you really end up filling in a lot of cracks in other places as well. So I really like to start wherever we start. And I believe that no matter where you start, you can make improvements in multiple areas just by sort of getting people to address and consider that things could be a bit better. We don't have to take it at face value and deal with pain or suffering on our own.
So I'm sure that some patients have a lot of things on their mind that they'd like to talk about with you. Mm-hmm. For those who are more reticent, what's the most important question that you ask somebody to get them started in engaging in the process with you?
Mm-hmm. Well, I think it helps that I come from a culture where we don't actually believe in psychiatry, and we don't believe in talking about our feelings and all of that. So, you know, coming from a culture where none of that was natural, I think it does help, because I'm able to put on the table that if you aren't someone who's comfortable with all of that, you know, we can really start wherever you are comfortable. So we can talk about pain, we can talk about constipation, we can talk about your children and how they're bugging you. Like, it doesn't really matter. You know, once you start to talk to someone, and once we sit in the room and we can be human together, we get somewhere. So, you know, no matter how reticent, and I have to say, like, you know, coming from where I come, we do not talk about emotions. We just stuff everything down. So really for me, what the impetus is just to get anything off the plate. And once we start to get things off the plate, it's amazing. It's kind of a domino effect. You just start to roll with it. So yeah, so I just ask, you know, what would be the one thing I could take off your plate? And sometimes it's something small, sometimes it's something big, but it always leads to more and more and more.
I like that.
Never not worked.
What's the one thing you can take off their plate? That's perfect. That's great.
Mm-hmm. Start
focused. Dr. Terpenning, when people are asked questions like that, what can we help you with? What's the most often? What do they mention most often? What are they most struggling with as a general rule?
I think that I would second what Dr. Gowrinathan said, is most people would say, oh, I'm doing okay, or I'm having a terrible time, but I don't really know how to handle it. Mm-hmm. So sometimes it's very hard to help someone open up. But usually the problems that unfold are their own anxiety about the cancer diagnosis, fear of death, children and husbands, spouses, or wives, and trying to help them deal with it. They worry very much about those individuals and often put that before their own fears. I think finances is a major issue for people. Will my insurance be covering this? The cost of cancer treatment can be very high. So good financial counseling can be made available to individuals. And I think that also just with fear of what's going to happen to their body, to themselves. Will they be able to work again? Will they be able to keep their jobs and their dreams? For some, it can be loss of fertility, which can happen secondary to cancer treatment. crushed dreams of family that may not be able to happen in the way they had envisioned it. It's a very personal experience, and it takes, as Dr. Gowrinathan said, tact and quiet probing to be able to help people feel comfortable enough to share with you the things that they worry about. I think that having a supportive environment in your practice or being able to work with someone in a supportive environment such as Dr. Gowrinathan and Anna is wonderful, because those individuals are skilled at helping support people. I think that it's really important for people to be heard, but oftentimes they have to find their voice. And I think that's really what the difficulty is in the beginning, because they're very overwhelmed. As weeks go by, as months go by, they acquire much more ability to enunciate what they feel their greatest issues are. But in the beginning, they're overwhelmed sometimes and really can't figure out who's going to pick my kid up from school. It really comes down to those basics that are important to help address and put on the table, sometimes voluntarily. Do you have any childcare issues? Do you have any concern about your job? Will your employer be able to give you a leave? Those kinds of leading questions sometimes help people open up quickly to lead to solving some immediate problems that develop post-diagnosis.
So tell me a little bit about how this works ideally. Do you meet with the patient alone? Do you meet with the patient and their significant other, or the whole family? Or is it different for everybody?
It depends on the person. Usually I've always asked people to bring someone with them to be a good listener and a recorder, because the person really needs to have someone else whose brain is functioning to be able to take care of things. Oftentimes it's a spouse, oftentimes it's a best friend. Sometimes it's not a spouse, because the spouse may not be able to manage the situation initially. Sometimes it's whole families. Sometimes 10 people will want to get into the room to come and visit and ask all their questions, and they'll bring lists of questions. I think that what it's good to do is to make everyone feel engaged and ask them to bring a list of their questions so we can go through them so they feel heard, because people sometimes forget what they want to ask once they're in the doctor's examination room. And so I think it's very important to set time aside for that as part of the consultation. Again, it's a life impacting diagnosis, like having a massive heart attack or a stroke. So you need to comprehend the whole person and their whole family in order to be able to help them begin to construct a new reality to the life they've been living, and find the pieces and put them in new places to be able to go forwards with their life. It takes time, but it's really a worthwhile investment for the patient and their family, because they begin to see a new future for themselves and begin to regain some hope of what that's going to mean. And I think that's been my experience as an oncologist. It's very time well spent.
So Anna, patients need to have some kind of a roadmap as they get started, or even once they're in the process of treatment. What exactly is a survivorship care plan? How do they help people? Why do they need that?
Right. So it's no secret that cancer is made up of very complex treatment modalities. That is definitely no secret. A survivorship care plan, as you said, can be a roadmap of sorts. It is an individualized, comprehensive account of specific cancer treatment history, which includes detailed information on the type of cancer, the stage, pathology. It also contains information on the treatment received, which can include surgery, chemotherapy, immunotherapy, endocrine therapy, radiation, along with the name of the drugs that were given, the dose that was given, the route or the area that was treated. It also contains information on the recommended follow-up care and monitoring, which can include labs, imaging, how often to see the healthcare provider, and when specific tests need to be done. It can also include information such as potential long-term effects or the risk of recurrence. So it really contains a lot of information in a small, in just a few pages. So there's resources, psychosocial support services, nutrition, information that is really valuable for the patient.
So, I'm sure your experience is similar to mine, that patients, on the drive home, remember the most critical question they forgot to ask while they were in the clinic. or they're confused about when to get back in touch when they have new symptoms. How do you handle that? Do they have instructions on who to call, when to call, what to do?
Yes, the care plan also includes information about the providers, their specialty, and their contact information. I also advise patients to, if a question is keeping them up at night, keep a notepad by their table, bedside table with a pen. They can write it down or reach for their phone and write it down there, and then try to get back to sleep, because sleep is so important. So keeping that there, and then the next day calling their care team to find, to ask the question. So those things, we don't really want that to keep them up at night, but making sure that they're addressed is also equally important.
Who exactly do they call? Do they call you? Do they call the medical oncologist? Do they call the surgeon? There's a big care team.
Yes, there is a very large care team. They are more than welcome to call me, especially if we just met, the night before or the day before. But I can then guide them in the right direction. Let's check with your oncologist, or let's check with your surgeon and find out more.
Mm-hmm. Okay. Dr. Gowrinathan, how do people, how do you coach people on knowing what's quote normal to go through emotionally and psychologically after a diagnosis of cancer, and what's something that is extreme enough that specific therapy needs to be started?
So I think one of the things that I like to really sort of dispel, and I would love for this not to be what people think anymore, is the concept that because I have cancer, I should be depressed, or because I have cancer, I should be anxious. So, when we have these big life events that shift us, and then in the case of cancer, when there's also a feeling of being rather uncomfortably close to, illness and mortality, that should mean that we should be upset a little bit, but depression and anxiety are very different things. And the way I describe it to people is depression and anxiety will feel like something that's external, like it's coming onto you, it's outside of you. Sometimes for depression, I describe it as lead boots. You want to get up and get going, but you have these lead boots on. And sometimes if the depression's really bad, we've got lead boots on and we're underwater. And we're just kind of like walking underwater, watching the world, with lead boots on. So there's the true depression and true anxiety. The problem is that they do not allow us to live for even a moment. We're being held back by an emotional state that is coming from dysregulation in the brain. And that is very different from feeling anxious before we go for a test or an MRI, or feeling depressed because we are losing function and we are debilitated. But I think in all aspects, even if we're just anxious before a test, or we're depressed because we're losing some function and we're feeling a little debilitated, I think it's really good to have someone to talk to and sort of sort through, how am I going to cope with this differently? How am I not going to let this slide into something uglier? And I think that a lot of times in cancer, patients feel very much like they can't talk about what they're going through. Either they feel like they should be grateful because they've survived, or they feel like they are trying to protect their family and friends because everyone's already so frightened for them. So I think giving people a space to just talk about whatever it is the first step. We don't need to pathologize, we don't need to diagnose. It's really just talking about what's going on and trying to lighten that for people. And then, yes, there are times when people fall into what would be classified as a clinical depression or severe anxiety that meets criteria as a disorder. In those cases, it truly is, you are not yourself. You do not feel like yourself. You don't understand where these feelings are coming from. And it's almost like you're watching yourself go through this and you don't recognize what's happening as organic to you. And that is a clinical disorder that requires treatment. The nice thing, though, is no matter what your cancer is doing, the depression and the anxiety are highly treatable. And that's the other takeaway I would love people to consider. these are some of the most treatable illnesses that we have. So it's worth looking at how can we get rid of this? Why do we have to have this extra burden while going through cancer? Let's get rid of that so that people can be stronger and get through the cancer and move on.
Treatable with medication, with antidepressants, and
with everything. They're highly treatable. I think people assume because I'm a psychiatrist, I like to throw pills at things, and I do when it's appropriate, but I also truly believe in things like what Dr. Terpenning was talking about. My patients will tell you that I'm very, very adamant for when we're starting to feel better, then we're going to start to exercise. Or, once I've gotten you moving with a little medicine and we're feeling a little lighter, we're going to talk about what behavioral interventions we can put into our world, therapy, support groups, lunch dates with friends, walking on the beach, whatever it is that we can put to create a scaffolding so that when I take that medication away, you have what you need to support yourself without meds. So I see the meds as sort of crutches in a cast.
Mhm.
It's just a temporary thing, and then we get you standing again.
Mhm. Good. Dr. Terpenning, I'm sure that there are things that the medical and surgical oncologists might do better. We all have opportunities to improve, of course. What frustrates you? What things do the medical doctors managing the biology and managing the medications, what are they doing that upsets you, that you feel could be done better in the global picture of support for the patient?
I understand you correctly. What you're asking me is what could medical oncologists and surgeons and others treating cancer do to better communicate with their patients and support them? Is that
Right. Yes, that's right.
Yeah. Okay. To the best of their ability to be present in the moment would be my answer to that. It's very difficult from this perspective of the physician taking care of many people in crisis to always be able to focus on the individual when there's another individual or other individuals who also need your attention and care. So I think that's a very challenging issue. I think the way that I've dealt with it throughout my career is to try to have the best support team possible with nursing staff and nurse practitioners to assist, to support patients. If I had to take care of a crisis and then go back into the room and talk to the individual again. I think one thing that's important to do is to acknowledge it. And at moments when it's dizzyingly busy, I think it's very good to look a person in the eye and say, I want to stop and speak with you right now. And I would like to do that. I cannot at the moment, but I'd like to ask you to wait for me for a few minutes and I'll be able to clear up some time and come back and speak with you, because I think it's important that I hear what you want to say and that I listen to you and be able to give you the support that you need from me. I think being honest with an individual is very helpful. They certainly, rather than hustling through, hoping the patient doesn't really need what they're asking you for, and hoping that they, excuse me. I think those are some suggestions I've had to surgeons. Is if they really have too busy a schedule as a surgeon or an oncologist, is to have someone with them in the room at the time, or to be able to refer to a staff member who knows the patient already, to ask them to wait with the patient or to be with the patient. But I think it's most important to acknowledge that the person has an issue and they're asking for help. I think the worst thing that we can do as physicians is to ignore that.
Okay. So in managing patients in your practice. Okay. In managing patients in your practice, what are the things that they should know that they should be calling about? What are the things that they don't call readily enough about when they're at home? Because patients are often confused about what they should notify their doctors about.
We're always very specific and let people know exactly what to call for. And as a backup, if they have any concern or confusion, we ask them to call us first anyway, especially when they're on treatment. So it's important that someone never feel that they couldn't disturb the oncologist. I think that that's So that's a contract that we make with every patient. If they're listening to it, it sounds as if it'd be better for someone to see their internist for it or their urologist for it, then we advise that. But sometimes the side effects of treatment or long-term complications of cancer treatment need to be heard by an oncologist first because they can filter them properly. As I mentioned earlier, the great day we're going to get to eventually is when all different specialists understand the needs of cancer survivors, whether they're on treatment or afterwards, so they know how to interpret some symptoms that they otherwise would interpret a different way because they're not thinking of it in the cancer context or a cancer treatment context. So for better or for worse, oncologists and surgeons who have treated cancer still remain an excellent, radiation therapists become an excellent resource for people to know if it's cancer related or not and give them that reassurance. This is not something you need to see me for right now. This is something that your internist can manage, or I'd like to see you first. I think it's important that I check you out and then we can send you on to another doctor if it turns out to be unrelated to anything. And practice pattern over the years has served me very well, our group very well. That way we don't miss someone who has a relatively obscure side effect of cancer treatment that might be missed by a general practitioner or someone who doesn't treat a volume of cancer patients. And yet we can quickly dispense with it, often on the phone, if we know that it's something that we can manage easily and not have a person enter a circuit of seeing 1, 2, 3, 4 doctors before they eventually get back to us.
That's helpful. Thanks. Anna, what should people do to just stay generally as healthy as possible? They're often consumed with the details of cancer therapy, but what should they be doing to sustain their overall well-being and their general health and their level of fitness?
Right. So I think about these following categories. So stress. We know that stress can cause inflammation in our bodies. It can rob us of sleep, focus, eating well, and joy. So finding ways to de-stress, such as meditation, going for walks, spending time doing things that bring us joy. That may be spending time with family or, setting time aside to read a book. Sleep is also important. So trying to get good sleep, turning off all the gadgets, making the bedroom a peaceful place, and shooting for 7 to 8 hours of sleep. During sleep, we know that we refresh, we recover, and renew our bodies. Too little sleep or too much sleep can be bad for our health. Nutrition is also important. So staying away from fads, fasting, and fakes. The best way to stay healthy is to eat a variety of vegetables, fiber, fruit. If you eat meat, make it lean, and not to forget to hydrate with at least 8 to 10 cups of water a day. If you have specific questions about, asking or specific questions about the latest and greatest internet craze for nutrition, check with your healthcare provider and seek out the help of a registered dietitian, which we have in our cancer center. They are trained in cancer specifically and can help optimize nutrition and reduce the risk of recurrence. And then lastly, physical activity. Walk, walk, walk. It doesn't take any fancy equipment or a gym membership to be active. Trying for 30 minutes a day is important. If that seems to be too much, you can split it up, 10, 10, and 10, and then slowly increase over time. So those are some ways.
So what's a cancer survivor diet? Are there specific anti-cancer foods? Are there specific anti-cancer supplements that people should take?
I think with every consideration for any supplement should definitely be reviewed. Some supplements can increase our risk of bleeding or can cause liver toxicity. So those things are, and diets as well for that matter. So talking with the oncologist, the surgeon, the registered dietitian can really help with that.
Okay. Dr. Terpenning, what do you recommend for a diet? What's the cancer survivor diet?
Eliminate red meat as much as possible, or limit to 1 serving a week. Fresh fish or chicken, lean meat when one has meat. 4 to 5 servings of fresh fruits and vegetables a day. High fiber. Drinking lots of water. Limiting alcohol. to most 1 drink a day, and exercise, which is part of nutrition today. So I think they try to eliminate concentrated sweets. But that doesn't mean you don't have fun and have blowout times at family barbecues or parties and things like that. Because everything's in moderation. It's what you're generally doing most of the time that matters. And that's an important point to stress, because so many people become fearful that everything that they're doing after a cancer diagnosis could contribute to their risk for recurrence. And furthermore, they're worried that they're harming their family by doing anything wrong. It becomes very much of a psychological trap for them. So it's important to help people regain some sense of balance, and realize that occasional splurges aren't going to damage them.
Mhm.
That is basic. It's better to keep a basically healthy diet. And that's the guidelines that I give, the American Heart Association diet, pretty much.
Yeah, sounds good. Dr. Gowrinathan, what's the main challenge, problem, stressor that you see in the significant other, in the spouse of the patient?
Yeah, so that is one of the areas where that's a goal of ours right now, where I think we're doing a much better job of meeting the needs of patients, especially over the past couple of years. But I think that caregivers, kind of fall by the wayside in terms of, there's certain services that are really only paid for the patient. But cancer is one of those illnesses that really affects everyone in the family, the spouse, the child, the family members, mothers, brothers. And so I think the biggest problem is just that we don't have services that recognize that everyone is going through this diagnosis with this patient. And on the flip side, for patients who don't have anyone, there are patients that we have who truly don't have anyone. And on both sides, it's really a juggling act. The teams have to think creatively to be able to offer resources either to the isolated patient or the patient with family members that are suffering. And I think that that's a shame. I think if we recognized that treating the family and treating the people around helps the patient and improves outcomes, we would be doing a better job. So right now, I would say that the biggest problem is just that we don't have anything to offer that's significant for caregivers. And then for people who don't have support, again, we don't have enough to offer.
Dr. Terpenning, at some point in the course of cancer, for too many patients, you've run out of options, and the cancer's progressed to probably an irreversible stage. How do you help patients when the end appears to be approaching? How do you help them and their families plan for that?
Well, I'm always very frank with my patients about this. I usually have a schedule, a sit-down meeting, and I plan for it in advance. I think privately about the patient and my experience with them and their family, and the impact, and try to couch how I present this to the individual very carefully, so they're able to hear it as best as possible and be able to work with it, not necessarily accept it, and talk about options. Oftentimes people will ask me whether options exist. I can explain them to them. And also sometimes I recommend that no further treatment is necessary, because the treatment would harm them more than supportive care at that point in time, rather than have them be ill from side effects of treatment. I think it's important to have a follow-up meeting after that. So I usually take it very seriously. And so I do a series of meetings. And then I'll also meet with the family members separately with my patient's permission. Oftentimes the spouse or the caregiver or the children can't ask questions in front of the patient that they wish to ask. There's very personal questions about home life, care, things that they're afraid of that the individual with cancer may not be able to yet start to think about. And so I think with patients, respectfully with patients' opinions of permission, I like to give the family an audience to meet with them for half an hour, 45 minutes or more, to help answer their questions, so that they've had someone that they have worked with for years sometimes be able to answer questions that are important to them, and to help them get into counseling or support as they need it. That will then help the family be buoyed up enough to deal with the crisis that's impending and the potential loss. So I think it needs to be done very carefully and thoughtfully. It's one of the most important transitions in patient care. And the family is a major part of that. For those who don't have family, as Dr. Gowrinathan pointed out, and that is a certain number of our patients, I think it's important to think of other options for support for them. Oftentimes it's the staff in the office or myself that we're supporting, just giving phone calls every couple of days and checking in on people and making sure they know they're cared for, or helping them to get connected with some support groups that might be helpful for them in this situation of transition. So I think it takes a special type of thoughtfulness and consideration and individual approaches in order to be able to optimally help someone.
Thank you. We have some questions that have come in. One specific request, and we can work on providing this. Lynn asks, can you provide the website address for social services, either internal to St. John's or outside of our health system? So that's something that we will follow up with, and perhaps we can put in the chat box before we finish. Nancy asks, with more cancer patients surviving for longer periods of time, what kind of assistance can be provided to long-term cancer survivors who experience late side effects years after treatment? For instance, a patient with head and neck cancer recently diagnosed with osteoradionecrosis from radiation therapy. What do we have available for these late side effects? Perhaps Dr. Terpenning, you can start.
Sure. This is an important area of survivorship, and what I was alluding to earlier, when people will have delayed side effects, their internists may not be able to pick it up because they haven't been educated or had experience with that. So I think that it never hurts to call back the original oncologist and see if there's anything that could be their cancer treatment. And certainly I have patients calling me back 15, 20 years after I treated them for complications or secondary cancers and wanting input because they're new oncologists in another part of the country where they've relocated, doesn't have all the information they need to make the right decision. So I think a relationship is a long-term relationship. And so whenever there's a long-term complication or if someone has a health problem after a cancer diagnosis, I don't know many oncologists that will push them off if they send a note or an email that would say, could this possibly be related to my former cancer and its treatment? I think that that's not a bad approach to start out with, or encourage their physician, their general internist to contact the doctor to see if that could be the case also.
Yeah.
I think that would be a good approach.
Okay. And do most oncologists have experience with the specific medical management of these late complications that can occur a decade or two later?
Yes, actually so, because many of us follow our patients for long periods of time. And so I think that, although in some healthcare systems, people with cancer who don't have a recurrence by 3 years are turned over to family practitioners or internists, as many oncologists as can still follow their patients or remain somewhere close in touch with them so they can be reached again. They're not reachable. And yes, those complications, anyone who's been practicing for more than 10 years will have experience with common complications. That's part of a medical oncologist training to be taught about the long-term complications of cancer treatment. So we are all taught about osteonecrosis and the jaw and of the spine post-radiation, delayed esophageal cancer after thoracic radiation for lung cancer, for example, breast cancer after radiation for Hodgkin's disease. We are all educated in those phenomena. So I think that a medical oncologist is a good resource at that time. And it seems unlikely that unless the person's no longer practicing, and even so, one of their former partners might be able to help someone from the records to direct that treatment.
Good. Okay. Dr. Gowrinathan, Michael asks about how to communicate with one's physician about issues, psychological or other ways. He asks, what about What about email as an alternative to a phone call? He says it seems like a good idea for people to write down their question and have an answer in written form so that they can review it and reflect on it later. But his experience, he says, is that some physicians are reluctant to provide their email address. How do you feel about email communication in the therapeutic process?
Well, I think that we're lucky that because we're living in a time period when there's 50 million different ways of communicating. There's a lot more than there used to be. And one of the ways that has been really successful over the past couple of years is that we now have the MyChart system, and you're able to use that system to communicate with your doctors, and it's coming into the chart. So, and full confession, as a patient, on the patient side of things, I didn't sign into my MyChart for a very long time, even though I was asked to do it multiple times because I was a little reluctant. But I will say, it's great because not only, if I'm in the middle of clinic and I'm seeing patients, I'm not going to get whatever message. You can email me, you can text me, but if I'm with patients, I'm not going to get that until I'm done with clinic that day because I'm focused on the patient in front of me. So it's really nice because the message can come in and, my assistants or someone in the office can pick up that message, and maybe I didn't need to be involved at all, or maybe they can send me a quick message I can answer and it can get resolved. So I do think that we have technology now that allows us to be able to communicate better. I agree, back in the day, it was a little kerfuffly, and phone calls, there was a lot of back and forth and phone tag, and I hate that when I'm trying to get a hold of the pediatrician or something. So I think that the MyChart system is a new great way. So if you haven't tried it yet, try it. I hate computers and I like it now. So it's definitely a way of getting an answer faster because you're not just relying on that physician who is probably, in your case, you'd be in surgery, or in our case, we're in clinic, and we're not going to be able to address that in real time. But there are people in the office who are able to do that. So I suggest using MyChart because you're right, it's just like email because you can go back and review that message as many times. When I go to the doctor, I forget what the doctor said to me. 5 seconds later, I've forgotten. So it really does help to have it to go and look back at. So I do agree written form is less ephemeral, Michael, but I also think that the MyChart system is nice because there's multiple layers to prevent your message from not getting answered. So it kind of makes sure that you get your answer. So I suggest trying that and see if that works better for you.
Of course, frankly, one of the concerns with email is if you're not able to answer it and there's an issue that sounds like an emergency, it sits there unattended in cyberspace. Mm-hmm. That's the problem.
That's exactly it. Because the doctor may not be checking email at that moment, and then now there's no recourse.
So if it's a question for which there's some flexibility in the timing of a response, it's a good option. If you're seriously worried about something and you need an answer right now, at least with a phone call, there's somebody on the other end listening now. Mm-hmm. So that's the one concern we have. Obviously, what you said about MyChart resonates with Michael. He says, I love MyChart. So that's a good strategy, and I would encourage people to use it. That's why it's, a lot of work has gone into developing it and promoting it and answering it. So we have added a couple of links in the chat that you can see that will guide you to some resources. There's also a note from Adelaide McLean, who wants to mention the Cancer Support Community LA for psychosocial support. Are you familiar with this, Anna?
Yes, I am, and we work very closely with them as well. We pre-pandemic, we had Qigong. We also had a caregiver support group that would meet regularly at St. John's once a week. And now with pandemic, everything has really gone virtual. So we look forward to bringing them back, hopefully post-pandemic. And we do refer quite a bit of patients over to them. So we have a very close working relationship.
Well, we're just about coming to the end of our time here. I'd like to open it up to our panelists to see if there's any critical issues that we just haven't touched upon. Dr. Terpenning, you want to start? You're still, I think you're on mute right now. I do that all the time.
I think we are covered quite a range of topics today, Dr. Martin. I don't think I have anything particularly more to say, except for, again, to give kudos to Dr. Gowrinathan and to Anna Rocha and all the team that works together to support patients with prior diagnosis of cancer, current diagnosis, and their families to help them get through all the different adjustments that are needed to thrive after a cancer diagnosis and survive.
Thank you. Well, thanks for participating. Anna, any other key issues we missed?
No, I think, survivorship program really is for all people with cancer, whether they have completed their treatment, because of the detailed and comprehensive review that I perform and resources that I'm familiar with. I get a pretty good sense of who the person was pre-cancer, where they are currently, and where they would like to be. I like to work with the patient and their family or loved ones to help them really achieve their own personal goals for wellness. And the cancer journey is often filled with peaks and valleys. Some people need a little bit of support, others may need a bit more. One example is an older gentleman that was referred to me for survivorship. He had stage 4 melanoma and had gone through several lines of treatment. Was diagnosed 20 years ago. Working with him and his partner, we were able to come up with a really great plan that was aligned with his personal goals. He has since gotten stronger with, home health, physical and occupational therapy. They have the equipment that they need to provide safe care at home. She's been able to make community connections to continue the care at home, which has really made her feel less isolated. So the patient and her partner and his partner has really felt supported and heard with the survivorship program. And survivorship really is more than just surviving, it's about thriving. I really do love the work that I do.
And we really appreciate it. Thank you. Dr. Gowrinathan, as a last issue, the services you provide are tremendously helpful to so many people, but there's not enough you to go around to everybody who needs it. How do you feel about promoting additional access through group therapy or even group telemedicine?
Yeah, so while you make me sound so very awesome and essential, I think that a lot of the credit for the progress that's made with my patients, I think it's my patients. And I think that people can use a number of resources to help themselves. I am a big fan of cancer support community. There are a lot of groups there that are helpful, and Qigong and yoga. I think that we're in a time period where we really can take advantage of things that we learned in the pandemic. And one of those things is that psychiatry, therapy, groups can be run virtually and still be effective. I think that as a sort of specialty, we were kind of anti all of that. We felt that it was in some way, less than. It's not the same, but it's been working very well. During the time of the pandemic, we were really able to reach a lot of people with telehealth. So I think that the opportunity is there now that we have the telehealth to have it not go away and really expand on what people have available to them. We live in a city where traffic is an issue. Coming in for a group is an issue because it's difficult. Commuting is god-awful sometimes. So I think one of the things is that we have an opportunity to really grow our telehealth resources and reach people in a way that we couldn't before. And that's one of the things that we are focusing on going forward. So yeah, no, I'm not enough. And not only am I not enough, I really shouldn't be the only thing that's happening in a patient's life. I think that, again, it's scaffolding, it's building support all around. So one person can't do that for another person. So I think as much as I try, I think what we need is to be able to grow services so that we're able to meet the need on multiple levels. And that would include groups and things. And that is our goal going forward. As the director, that's one of the things that I'm very focused upon is really growing things and taking advantage of what we learned during the pandemic.
So Dr. Martin, it's just a little bit after 1, so I'd love to wrap it up if that's okay. This has been a wonderful webinar. Thank you all so much for your time and information expertise. You know, it's really important information to help patients and their families, you know, during their cancer journey, and make it the healthiest and most holistic journey possible. But, you know, I do want to say, as you can see behind me, giving saves lives, and I'm a you know, foundation person here. We work to support the raise money for cancer support services, and much of this work would not be possible without the philanthropic support of many of you. And so we can't do this without your help. And so, you know, if you're interested in supporting us, we'd love to hear from you. Please, you know, I'll reach out to everybody once, and it would be great to hear back from you. But we offer wonderful programs for free for people who need that help. Nutritional counseling programs, you know, for people that are scholarships for them. We've got some financial assistance programs. We've got meditation programs that are coming up. These are all going to be free for our patients. And we do that, we're able to do that because of your help. So, you know, please consider your support. And we hope that you'll join us for future webinars. In July, on the 17th, we've got prostate cancer active surveillance and early stage treatment. In August, melanoma and cutaneous skin cancer updates. And in September, we're doing a bone health webinar bone health during cancer treatment and the importance of vitamin D. So thank you again so much for being with us today. And we look forward to seeing you again soon. Take care.